So good morning, everybody. Very welcome to the Chinese delegation under the leading of Professor Ying-Zi Zhang, who is the president of the Chinese Orthopaedic Association. So we have a common session this morning, and together with my colleague Freddy Grützner, we will run this session, who also welcomes you this morning. We are very glad that many people came to this session. We have some very honored speakers here as well from China and Germany about revision surgery in tibial plateau fractures. This is, in my eyes, a very interesting topic, and especially our Chinese colleagues. They have very high caseloads in this field and also a high experience to treat these difficult situations. So our first speaker is the president of the Chinese Orthopaedic Association, Professor Ying-Zi Zhang. Please go to the microphone, and he will tell us about minimal invasive treatment of tibial plateau fractures. And maybe you also have some words for us. Very welcome here in Germany. The session will be in English, and it will be simultaneously translated to Chinese or vice versa by the microphones. So, Professor Ying-Zi Zhang, please go ahead.
So we are a total of 7 persons here. And actually, this is the fifth time that I had the opportunity to participate in your meeting, and I also extend my warmest gratitude to the German host. And I'm going to talk about today about the minimally invasive surgery. And in 1909, we had the German Dr. Meerwan. He was the first to perform the tibial plateau fracture open incision and reduction following screw internal fixation surgery. And so this is and he had this case, these 4 cases, and they were all military, they were all soldiers. And China only in the 50s started, so in 1950. So we had a orthopedic surgeon, his name is Fang Xianzhi, and he performed the first surgery. So this was 41 years later than Germany. And then again in 1980 we had another medical doctor of Chen Yichang. So he published the first Chinese paper on this issue. And so this is the first treatment or the first published report. So far now we have, with regard to the tibial plateau fractures, there are a total of 2,475 articles in paper, and in Chinese there is 13,500 papers to be published in China. And so this here we have on the minimally invasive treatment. So 3D printed preoperative planning is 2.1% of all papers, and there are a number of English papers. For the English papers, so the questions is on fracture types. This and open surgery. So open surgery is 18%, and 3D. So minimally invasive treatment is only 5.4% of all papers. So here we compare this literature in English and Chinese, and the postoperative effect. So the Chinese paper papers, 19% of the Chinese papers discuss, only 7% of English papers. And if we look at the complex tibial plateau fracture, we see that's around 18%. And the arthroscopic assisted treatment, it's close to 15% in the Chinese literature, so the coverage in papers, and it's close to 9% in English literature. And then from 1909 to today, we have 115 years. And so, and in these 115 years, we had a lot of research going on. And we can see how the incisional infection rate goes, how the dysfunction is distributed, and all of it is open reduction. So, and in current, AO retractor is and other external fixator traction is the method of choice abroad, but in China we do it in a different manner. So in 1978, we started to develop our own homeopathic bidirection traction reducer. And I want to talk a bit slower. So I want to make it clear, so we do not do open surgery anymore. And we do not do reductions in the classical sense anymore. So here you have here you see our own traction reductor, bidirection traction reductor, and you see you see the differences. So this element here is a flat element. And now we have a small video which shows you what happens. And our German colleagues witnessed our surgery in practice. So they came and saw what we did. And here you have an animation of it. So now what you do is the fractured part is fixated with a nail. And in post-operation, what we do, so it is immediate mobilization, so the patient is mobilized immediately. And also immediately mobilized. So and here you see the wounds, which are quite small. So the openings to the lesions to the skin are very small. And then of course that what we do here is to strike the sole of the foot and using the femoral condyle as a template for flexion and extension. And here we have another picture of the lesion after the operation. So this is a quite even a complex fracture, plateau fracture, only takes us about 40 minutes in operation time. And especially with the mobility of the knee, or the mobilization of the knee during and after surgery. You see this comparison table. So as a summary, so the bidirection traction and brace top reduction is one possibility to treat fractures with collapsed fragments. And then you have an X-ray here. So and so here we have a Schätzke type 2 fracture, tibial plateau fracture. And here you have so here you have the situation. So the reductor is applied, then the nail is introduced. And the reduction is complete in this. And in the channel, so in the channel we do perform bone grafting. And this is also the situation immediately post-operational. And here again we also have the incision to the skin. And here we also have the lateral compartment in arthroscopy. And you can see that the reduction in position is 100% correct. So, and now you see the functional recovery after operation. And within 12 months after operation, we have a recovery rate of about 98%. So the HSS score is 98. So here we have another tibial plateau fracture. And on the left side you see the arthroscopical view of the lateral compartment. And here we also do a reinforcement with and here again we also see the mobility after operation, and here the score is the HSS score is also 98 12 months after the operation. So here we have a Shetsker type 5 fracture. It's a bilateral platform fracture. And here we managed to reduce basically. So it was done in a satisfying manner. Let's put it that way. And here you can see there's a. So here again, so another arthroscopical image. Again, also the incisions after the operation, so this is immediately after. So this is also a double with a double implant. And here the HSS score is 96. Here we have a complex fracture. And here you see the process of intervention. And you can see here actually on the video so that we also managed to reach a complete recovery and repositioning. And here again, we have a invasive replacement splint, and you see splint, and you see the results. So not only the X-ray post-operatively, but also that an HSS score within 12 months after operation, we reached 99 points. So then there are also fractures without collapsed fragments. And in this case, so the type 4 fracture, in this case, what we do here is to immediately apply the traction reductor. So you can see that on the right side, you can see there's a screw. Again, the incisions after operation. And also, of course, here the X-ray and the mobility demonstration. And here we reach a HSS score of 96. So another type, so type 6 tibial plateau fracture. And here you see the method how we do it. So we have a reduced fracture after bidirection traction. And so we basically resumed the original position. And then you can see the steel reinforcement or the fixator, and again here the arthroscopic view of the lateral compartment, as well as the pictures of the post-operative incisions.
我们还发现了一个胫骨平台，
So we
这
have
个是好发骨折，是德国人好发。
So then there's also another type. This is was the
我们根据牛顿的3大定律，作用力、反作用力相等。我们做了一个实验，结果胫骨平台也有好发。我们不叫好发，我们叫张氏骨折。张氏骨折。
but this is another name is now Zhang style or Zhang fracture treatment.
这是我们做了10例病人。
So here we have 10 cases so far.
我们有7例都做了这个都做出了平台骨折，这是术后的
And
X 光片。
then we have, so far in 7 cases, we have the repositioning here, and you see the X-ray on the, so, and
这
then also
是
you
术
see
后
the
复位的结果。
the post-operative
这是切口。
operative CT, and also again here the incisions.
这个好处我就不说了，我一共办
So,
了到现
and
在
of course
办了
the
127学习
advantages
班。
speak for themselves. I have conducted more than 800 or close to 820 interventions.
这是德国的几位朋友，你们都认识。
So, and there's a number of German friends who you all are familiar with.
他们去年的时候，他们正在看我的手术。
And they came to China last year and they observed my operation, so my surgery.
我在他们面前表演了3例，
And so I demonstrated 3 cases.
术后都做关节镜，他们都看了。
And they all could convince themselves by personal look, so by personal inspection of the success of the method.
我这种方法在中国1000多家医院应用。
So, and so far actually more than 1,000 hospitals in China have promoted this in minimally invasive technology all over China.
这个
And
我们这个
our-
微创手术
So, and our minimally invasive surgery technique
不只是下复位，
is not only helpful so in achieving the reduction,
和德国完全不一样了。
and it's completely different from what you do in Germany.
所以这是中国方案。
And so I just can proudly claim that this is the Chinese solution.
谢谢大家。
Thank you very much for your attention.
Professor Zhang, thank you very much. This was a very impressive lecture, and I'm really surprised about your technique and absolutely convinced that you are following the right way. Thank you so much. I guess the audience is impressed as well, and this is a real new principle, and it's overwhelming to see how many surgeons you already have taught in this technique over China. So tibial plateau fracture is not a severe problem anymore and does not cause disability anymore in China. So thank you so much. Great talk. Next talk. This talk was how to prevent from revision surgery. The next talk is what to do if it did not work, what some surgeons tried to do with the tibial plateau fractures, and it's a great honor to overhand to Professor Karl-Heinz Frosch from Hamburg. He's one of the most experienced tibial plateau fracture surgeons in Germany and has a big experience, and therefore he can tell us something about revision surgery in tibial plateau fractures. Karl-Heinz.
So thank you very much, Freddie, dear ladies and gentlemen. Professor Ying-Tze Zhang, great talk. Thank you very much. Very interesting, and we had the chance last year to observe you in the operating room. it's really as you have shown us in your pictures. So thank you very much. That was impressive, and it also made me think about my own technique, because we also do arthroscopic tibial plateau fracture treatment, but also do it, I would say, in most cases open. But that made me think about. Thank you very much. So let me talk about revision surgery. We all know that steps and gaps in the tibial plateau less than 2.5 millimeters or less than 2 millimeters cause osteoarthritis. So even if the ankle varus or valgus, in most cases it's a valgus more than 4 or 5 degrees, it's already a risk factor for osteoarthritis. So if we have a malunited fracture, that can be a very difficult situation. You have to completely analyze and differentiate the fracture morphology and also the reasons why there was a malunion, or maybe why there are pain and limited range of motion, for example, who is suffering, from which suffering the patient. So it's very important to differentiate between intra-articular pathologies. It's very difficult to evaluate all these pathologies, including ligamentous instabilities, which we call true instabilities, or pseudo-instabilities, which we call if there's a bony depression, for example, and you have the feeling that it's opened up the lateral joint space. This is usually a pseudo-instability due to a bony deformity. Axis deviation, soft tissue problems. I think an intact meniscus is very important, especially for tibial plateau revision surgery, and also the grade of osteoarthritis. If you have end-stage osteoarthritis, no one would probably do an intra-articular osteotomy. You would do an arthroplasty. So what is the main reason for failure? It's an insufficient visualization of the fracture. However, you have to visualize the fracture, even with an arthroscope like Professor Zhang, or you have to visualize it open, but you have to visualize. And this is a study of Meulenkamp, it's not our group, from 2016. This is the area where he found the most steps and gaps and the reason why there was a revision. So this was in more than 50% of the cases in the posterolateral central area. As you see here, posterolateral central. This is the main area why revision surgery has to be performed in tibial plateau fractures. So for us, this is the reason. Number one, you have to visualize it intraoperatively. Number two, you have to do the right approach. The right approach can also be arthroscopically, but you have to do the right approach to reduce and fix this fracture in the posterolateral central segment. Let me show you a case example. This is a case from our department. You see here this fracture, posterolateral central, and this was the postoperative picture in the morning. I saw, so everybody probably would say grade reduction. But again, posterolateral central and visualization is a topic, because this is the post-op CT scan. So a nice post-op X-ray does nothing say about the quality of reduction. The quality of reduction has to be either evaluated by arthroscope, by direct visualization, or CT scan. Fluoroscopy fails in 8 out of 9 cases to have really the right reduction. So we did an open approach, extended approach, and fixed it with an extended approach and full visualization. Number two, intra-articular remaining step. You see this picture, we always do a whole leg, we always do an MRI, we always do a CT scan in these revision cases. So you see here, best seen on the lateral X-ray view, you see the lateral plateau is depressed here. Here is a big step of around 1 centimeter, and it's a valgus deformity. Tenderness, lateral joint space, lateral pseudo-instability, and 30 degrees of flexion, positive pivot shift, It's a bony pivot shift. It's not a ligamentous pivot shift. It's also possible to have a bony pivot shift. And so this is the CT scan, and you see anterolateral is the main problem, so anterolateral approach. All these cases get an arthroscopy before intra-articular osteotomy, and then the lateral plateau was three-dimensionally osteotomized. This is a really difficult operation because you have to refracture, osteotomize the plateau intraoperatively in a three-dimensional manner. So we usually mark the osteotomy levels with K-wires, and then we do a three-dimensional osteotomy of the lateral plateau, as you see here, and we got a very nice reduction of this case, and this is the post-op X-ray, which shows also a very nice reduction, controlled arthroscopically in this case. Another case, even a little bit more difficult. This is the number one reason why we do revision surgery in tibial plateau fractures, posterolateral central, as you see here. This is the main reason why tibial plateau fractures get revision surgery, because here is a step gap or a defect, as you see here. And this usually occurs because people don't use the right approach or don't visualize enough the fracture. So also you see it on the X-ray here, it's an intra-articular problem. And in this case, there was a big defect. We osteotomized here the fragment, and in the fragment was a big defect. So we additionally used an osteochondral cylinder from the lateral epicondyle here and put it to this piece of tibial plateau fracture. And so this is the intraoperative view. You see this here. This has to be done open in my eyes. I don't think that this is possible to do it arthroscopically, Professor Ying-Tse-Zhang. I think in revision surgery, probably in most cases you have to do it open, but I'm really excited about your opinion. And this is the postoperative X-ray, which shows a really nice secondary reduction of this difficult cases. In most of these cases, we use an extended approach with an epicondyle osteotomy of the lateral epicondyle to get a really good visualization of the tibia plateau. Another case, this is a number 2, axis deformity. This is probably a more simple case, 62-year-old female patient, conservative therapy for tibial plateau fracture after 4 months, pain and a valgus deformity, severe valgus deformity. So this is a case, she never had knee pain or did not have severe knee pain prior the surgery. So for me, there was no reason to do an arthroplasty. So this was a simple osteotomy. You don't have to plan this really, because you do an osteotomy directly above the fibular head, and you extend the fracture as far as the lateral collateral ligament comes under extension. Then you have the original position, and usually if the leg was straight before, it will be straight afterwards. Allograft and a plate, and directly postoperative normal axis, and she was almost pain-free after 6 months. This is axis deformity in the sagittal plane. You see here the slope is around 25 degrees. So with such a slope, this patient was not able to fully extend the leg because there was a slope, tibial slope problem here, and as well an intra-articular deformity. Here was a step in the articular surface, so we had to do a combined intra and extra-articular osteotomy from posterior because we elevated the fracture from posterior. So it was an open wedge fracture from posterior, and this is the intraoperative X-ray. So we did fibular osteotomy again. It was already osteotomized. We did the fibular osteotomy again, elevated the tibial plateau, did an intra-articular osteotomy to get a nice reduction here of this step. And you see here the postoperative X-ray. Patient did fine, and the slope was completely corrected, and the leg was possible to extend it again. Limitations at the end of my talk, cartilage and meniscus, 74-year female attorney, complex tibial plateau fracture. As you see here, persisting pain, lateral pseudoinstability, slightly valgus. And what we did is an intra-articular osteotomy. The reason why you get such a good view is because there is no meniscus anymore. The meniscus was removed by first surgery. So in this case, probably I probably would recommend to do an arthroplasty, because in most cases, if the meniscus is gone and you do an intra-articular osteotomy, in most cases, to my opinion, it fails. In this case, it's 9 years after revision osteotomy, and already during the surgery, I saw in the fluoroscopy the completely collapsed lateral joint space. So I had the feeling this was a mistake to do an osteotomy directly during the surgery. This was the postoperative, this was the postoperative CT scan, shows a nice reduction, but nevertheless I had the feeling I made a mistake. So I always used this case to show that I might have a mistake, but the patient showed up 9 years later and told me, it's a great reduction, thank you very much. I'm still complete out of pain and can walk 10 to 12 kilometers without any problems. So it's sometimes also surprising. We examined 23 patients after malunited tibial plateau fractures and did an intra-articular osteotomy after 8.6 months after prior surgery, correction of intra-articular step from 9 to 0.6. All patients received a CT scan also postoperatively and were controlled. Axis correction from 7.2 degrees of valgus to 1.5 degrees, an excellent and good result. In around 3/3 of all patients, after 4 years, we had an excellent or good result. This is one failure case. In this case, you cannot do an intra-articular osteotomy. This is an intra-articular necrosis that happens very seldom, but it's an avascular, aseptic intra-articular osteonecrosis after tibial plateau fracture. This only can be treated by an arthroplasty in my eyes. There's no way to treat this with any biologic solutions we have at the moment. The reduction was not too bad. Not optimal, but not too bad, but it did not heal. So let me conclude. The primary goal is anatomic reduction. Postoperative deformities after tibial plateau fracture, you have to do a thorough analysis of axis deviations and mal reduction. You need a differentiated clinical exam of tenderness points, ligamentous and pseudoligamentous instability. Intra-articular osteotomy or revisions after tibial plateau fractures need an exact analysis and planning. It's always an individual treatment concept. The surgeon has to have a high experience, and in our hands, it can lead to good and excellent clinical results of around 75% of the cases. You have cases where preserving of the joint is not possible, then you need an arthroplasty. It's around 10 to 15% which need an arthroplasty directly after, or in average 8 months after primary surgery. Thank you very much, and I'm very open for question, and thank you for the audience. Yeah.
Karl-Heinz, this was really excellent. You showed us all the possibilities you have, how to correct malunit tibia head fractures, and you also showed us the limitations, and this is also a very interesting and an important point. I guess we hear the following talks, and if we have some time lost over, so we can not lost over. So we can address some questions. Next talk, and it's really a great honor to have him here, is Professor Hui Zhang from Beijing. And Professor Zhang is dealing with a very complicated and dedicated problem in these entities at the tibia head. The treatment of the posterolateral corner rupture combined with anteromedial tibial plateau fractures, so a combination injury that needs a little bit more thinking and technique. And Professor Zhang, it's up to you. Thank you so much for being in Germany.
Thank you, President. It's my great honor to stand here. So, as begin, I want to share a very interesting case. This is a male, 21 years old, failed postlateral corner and ACL repair. And we can find this is a physical examination and to show the posterior instability. And this is a varus instability. And we can find the stress view. This patient have more than 10 millimeters posterior translation of the tibia, and the lateral gap opening is more than 20 millimeter. Also, he have a hyperextension of the knee. This patient come to my hospital because he have a very difficult when he walking. Every step, the knee will result in varus, and the alignment shows the varus knee. And from the CT scan, we can show there's the first operation is failed because there's a reduction of the anterior medial plateau fracture, and also, this patient got a posterolateral corner injury. So the injury direction was from posterolateral to anterior medial, so we call this a diagonal lesion. And this is for the treatment, we just performed the high tibial osteotomy, and we corrected the varus deformity and increased the tibial slope. And this video we take just 6 months after the high tibial osteotomy. He can walk by himself. It looks like normally. And also, 2 years later, we perform the X-ray again, and the alignment looks just as normal, and the stability is improved a little. The posterior from 10 millimeter to 7 millimeter, and the lateral gap opening from 22 to 17 millimeter. So it's a stability just improve a little, but alignment is good. So we think there should be some relationship between the posterolateral corner rupture and the anterior medial. The literature shows the anterior medial tibial plateau and the posterolateral corner injury. When we check the literature, we found this is some kind of rare disease. The first report is on 2001. The author have reported impingement fracture of the anterior medial tibial margin and combined the posterolateral corner disruption. And after that, there's 2003, there's six cases of MRI study, and after that is some case report. So this is we can say it's a rare disease. It's not so popular, but the clinical relevance I think is important because for the anterior medial tibial plateau fracture, that could be result in a varus deformity, and this kind of varus may be result the reconstructed posterolateral corner failure. So we think it's important to pay attention to this kind of lesion. And the incidence of this kind of lesion, we have performed a study retrospectively, and we have 273 consecutive patients with grade 2 PCL and posterolateral corner injury was included in the study, and we got 26 patients have the diagonal lesion. The incidence is around 10%, so it's rare, but it's in truth have some patients have this problem. But for the treatment, we have found two papers published in 2022. The first one, the author used a high tibial osteotomy to management this kind of lesion, and only in 10 patients. And another paper is published the same year, and the author used a single-stage anterior medial tibial plateau fracture fixation, and at the same time, he performed the posterolateral corner reconstruction, only in 9 patients. So I think there should be some controversy in the treatment. Is there any difference in the acute or chronic patient for the treatment, or we should choose one-stage or two-stage surgery? So we perform another study. It's also retrospective. We include more than 100 patients who have a diagnosis with chronic PCL and posterolateral corner reconstruction failure to receive the revision surgery in my hospital. And if the patient has a diagonal lesion, we include in this study. And then finally, we got 12 patients in 13 knee, including in this study. And the 10 was male, 2 was female. And the average age was 28 years old. All the patients was revision. This is the baseline. And from this table, we can see the weight-bearing line is varus knee, and all the patients have a posterior and posterolateral instability. So all the patients will perform the high tibial osteotomy, and we use a dural plan to crack the varus knee and slightly increase the tibial slope to protect to improve the posterior instability. And after the operation, we use, when we follow up 2 years later, when we use the alignment and the telos stress view and measure the slope for the post-operative evaluation. We also use gait analysis, and this is the result. We can find the pre-operative alignment is around 20%. The post-operative increased to about 42, and also we can have the post-tibial angle and the tibial slope and the posterior tibial translation, lateral gap opening, and also the varus according to the gait analysis. Both the data was improved. And for the 12 patients, there are only 4 patients they want to have the ligament reconstruction. And so that means about 67% of patients do not need a staged PCL or post-lateral corner reconstruction. So the treatment for the chronic lesion, we can think the open wedge high tibial osteotomy is pretty good. So that will include the varus correction and the tibial slope increasing. That can be improve the alignment of the lower extremity and the stability of the knee joint. So after that, more than 60% of patients do not need a staged post-lateral corner reconstruction. Because this time the topic is a revision tibial plateau fracture. So, but I think I want to share several minutes for the treatment of acute. I want to share another two very interesting cases. This is a 29-year-old traffic accident, right knee and anterior tibial plateau fracture and post-lateral corner rupture. Also, this patient has a peroneal nerve injury. And from the MRI, we can find the post-lateral corner structure includes a lateral collateral ligament and the popliteal tendon totally ruptured, and also the PCL and ACL rupture. So we can find the stress view. This patient have a posterior instability and a lateral gap opening. For this patient, we use PCL, we perform the PCL reconstruction using Achilles tendon allograft, and also at the same time we perform the posterolateral corner reconstruction. And this is 1 year later from the MRI, the ligament looks just okay. But 2 years later, it's totally different. We can find the alignment is varus and the lateral gap is a little opening. So when we check the posterolateral corner, it loose. So we think this patient need to take the brace, and after that he can walk. So we think this kind of diagonal lesion perhaps will be result of varus deformity, and this kind of varus will result in as the time goes by, it will result in posterolateral corner stretch out. This another case is totally different. It's also male, 35 years old football player, and right knee injury. From the CT scan and X-ray, we can show this anterior tibial margin fracture, and from the stress view and MRI, we can see the PCL is ruptured. The posterior translation is 9 millimeter. ACL looks good. And the posterolateral corner, we can see the lateral collateral ligament is totally ruptured, and also the popliteal tendon was peeled off lesion from the femoral insertion, and the lateral gap is around 17 millimeters. So for this patient, we can check he have a little varus knee and the posterior and the posterolateral instability. This patient, when we perform the scope, we can find the median meniscus is engaged in the gap of the fracture. So after that, we perform an open surgery and to perform the cartilage reduction and to put the bone graft inside for the support for the cartilage. And after that, we use a rim plate to fixation. And after that, because this patient have a little virus, so we perform the high tibial osteotomy just beneath the bone graft. This is a CT scan post-operatively. And 3 years later, when we perform the hardware remove, I have the chance to examine the knee with the scope. It looks good. And the alignment looks good. And very interesting is the stability. We can find from the preoperative posterior translation is 9 millimeter, and after the fixation of the fracture is decreased to only 4 millimeter, just as normal. And the lateral gap opening is significantly improved from 17 millimeter to 10 millimeter. I'm very sorry because in my hospital we have a trauma department, so the patient have fracture go to my department. I'm the knee guy to perform the ligament reconstruction. So I have a very limited chance to perform the fracture. So, and now I have only 5 cases of this kind of case. So I think the experience is limited. But for this patient, I think it's very encouraged treatment. This is the MRI. It's totally different from the 3 years ago. We can find the first picture, the ACL looks good, PCL looks recovered, and post-lateral corner, the lateral collateral ligament have recovered spontaneously. This patient, the stability is good. The patient do not need a ligament reconstruction. So I want to have a very short discussion. When we think the patient need 1-stage or 2-stage surgery, I think if the patient have a virus alignment, even for acute or chronic injury, a stage treatment plan is preferred with a high tibial osteotomy should be confirmed, should be performed first. Otherwise, the soft tissue graft may be stretched out. And from our study and the literature, we found that most patients after the surgery, they will have chance to avoid another post-lateral corner reconstruction. So the treatment for this kind of lesion treatment, I think, if the patient is a chronic or revision, I recommend a 2-stage surgery. First one is a high tibial osteotomy, and after that, if the patient thinks there's still instability, we can perform the ligament reconstruction. But for the acute patient, I think the most important thing is to anatomic reduction and internal fixation. After that, if there's still a virus, then you can perform the high tibial osteotomy. And after that, I think some patient can avoid another ligament reconstruction. That's all. Thank you for listening.
Professor Huizang, thank you very much for sharing your expertise in this very complex lesion. It's a rare but a very complex lesion, and you have to understand it. And thank you a lot for sharing your way of treatment of that lesion. We learned a lot of the diagonal lesion. Thank you so much. Next talk will be from Germany, University Hospital of Regensburg, Professor Volker Alt, one of the leading experts in infection surgery in Germany, and this is true, Volker. And you're leading the working group for infection in our society, and he has a lot of experience in infection surgery, and he addresses the infection after tibial plateau fracture. If you have that disaster, Volker gives you the solution.
Hopefully. Thank you very much, Freddie. Dear Professor Chang, dear Karl-Heinz, I'm delighted to speak about infected tibial plateau fractures. And we are going to talk about things like this. This is a clear sign of infection. It's called the Miro sign. So if the surgeon can see himself on the plate, that's the so-called Miro sign. And this is a clear sign that the site is infected. How do we name this? What's the terminology of this? In the last year or 20, 30 years ago, we talked about osteomyelitis, exogenous osteomyelitis, post-traumatic osteomyelitis. But in the recent years, we have established the term fracture-related infections. for all infections that occur after fracture treatment. And this is important because this is our complication after fracture surgery, and we should call those complications, those infections, we should call them fracture-related infections. This has been studied over the last years, and the term has been well established in the international literature. We have now clear criteria for those fracture-related infections, and I think with this term we have made good progress in the last years. So how does bone, how do our surgical sites get infected? We know that surgery can never be 100% sterile, so we always have a contamination of the wound. The bacteria will then adhere to the plate surface, to the implant surface. They will colonize the implant and finally will form a biofilm, which in its chronic state cannot be eliminated by the immune system or by antibiotics. The problem with the tibial plateau fracture, or with all fracture-related infections that are adjacent to a joint, is that the infection can go from the plate, from the bone, to the joint, and then lead to a septic destruction of the joint. And this is the danger of all the tibial plateau fracture infections, that we will then lose the knee joint due to septic destruction. What about the microorganisms? We all know that Staph aureus is the most common pathogen in this area. And interestingly, this is independent from time when the infection occurs. So we have looked at our own data. You see that 40% of all infections, fracture-related infections, are caused by Staph aureus. And this is independent from time. If you look at the early, the delayed, or the late infections, you see that Staph aureus is always around 40%. This is quite constant. And also the other microorganisms like Staph epi or the gram-negative bacteria, they are more or less in the same range, independent from time. So what are the risk factors for infections? We know that open fractures are at risk for this. This has been nicely shown in this paper. Closed fractures are at infection rate of 4%, open fractures of 14%. Also, fractures with compartment syndrome are at high risk for infection. This has been nicely shown in this paper, also regarding the treatment. When should you perform your fracture fixation in relation to the closure of the compartment syndrome? What would you guess? Should you do it before, at the same time, or after compartment closure? So these are the infection rates. If you do your surgery for open reduction internal fixation before closure, your infection rate is at 21%. If you do it after closure, it's at 21.6%. If you do it at the time of closure, you have the least infection risk with 15.9%. So if possible, with compartment syndrome, you should perform the wound closure exactly at the same time when you do your internal fixation. How do you diagnose a fracture-related infections? As I said before, we have made quite good steps forward with the so-called confirmatory signs, which are clinical signs like a sinus tract. You get the wound breakdown, or you got the purulent drainage out of the wound. This is preoperative. This is your only preoperative signs that can really confirm an infection. And during surgery, it is mandatory to take tissue samples for the microbiological and pathophysiological analysis. And if you have two identical microbes identified in your microbiology, this is also a confirmatory sign. And if your pathologist tells you that he can see bacteria or fungi, this is also a confirmatory sign. Or if you have the presence of more than 5 polynuclear cells, you also have a clear sign of infection. In addition to that, there are the so-called suggestive criteria that we know, like swelling, like redness, and also fever. These are suggestive criteria, but they do not confirm the infection yet. How should you take your tissue samples? If you suspect an infection, you should be very cautious with your sampling technique because you can have cross-contamination. Therefore, in this paper, and this is how we do it, we have sterile instruments for the biopsy of each specimen. So we have a pair of 5 sterile instruments. With those we take 5 different samples in order to always have a sterile instrument to avoid cross-contamination. You can also send your implants. You don't have to send the entire plates. It suffices that you take the screws that are at the fracture site or at the most the suspected site where the infection is, and this can be sent for sonication because sonication can take off the biofilm, which will improve your diagnosis. What are the treatment goals? You've got an infected bone, and in some cases you have an infected joint. So you want to have a stable and infection-free bone healing, but also a good restoration of your joint anatomy with good functional outcome. The general treatment for fracture-related infections, it's complex, but we have good treatment algorithms. The easiest situation is when your fracture has healed, you can just take out your implant. But in most cases, your fracture has not healed yet. Then you have to decide, can you retain the implant or can you not retain the implant? Do you have to exchange that? And what type of microorganisms do you have? Your hallmarks of your surgical treatment is that you have to debride your wound really thoroughly. It's always told that you have to do a radical resection, but a radical resection in a complex infection is amputation for me. So I don't like the term radical. We should do an adequate debridement. Then we have to use antibiotic therapy. We have to create a good stability of the fracture. If we have a significant bone defect, we need to reconstruct the bone. And if necessary, this is also very important for tibial plateau fractures, we need to do soft tissue reconstruction. But treatment, one treatment fits all. Do you think that all those infections can be treated in the same manner? No. But in many cases, we have to really analyze each case by case. And sometimes diagnosis is complex, and treatment, if you have soft tissue defect, this is also complicated. So we need multidisciplinary treatment. We have now established this multidisciplinary treatment in many centers in Germany and also in my hospital, and we could really show that with the expertise of the colleagues from microbiology, pathology, radiology for diagnosis, with vascular surgery, plastic surgery for the treatment planning, and also with infectious disease specialists that can really help us with the antibiotic therapy, we can improve outcome. We do the case analysis and discuss that. We make a decision, a treatment plan, and then we go for the treatment. And it's easy to show that with such a multidisciplinary treatment compared to a single decision by the surgeon, we can really significantly reduce amputation rates and also revision rates. Therefore, if you have the opportunity also in China to work together with your colleagues from the different disciplines, that's really helpful. So what about the functional outcome? Open tibial plateau fractures, difference between, we have seen this data, what's the difference in outcome? And it's obvious that patients that sustain an infection, that suffer from this complication, they have a worse functional outcome in the Oxford knee score. This is general. Conclusion is the presence of FRI significantly decreases the functional outcome. It's also shown in this paper where they have analyzed 35 cases with a two-stage protocol. So they took out all the infected bone, they took out the implants. They also showed that Staph aureus is the most frequently detected microorganism. They did this two-stage approach with the implantation of a PMMA spacer that was loaded with antibiotics. And their conclusion was that with a two-stage treatment, a good and satisfactory outcome can be achieved. Also, this paper from China, I couldn't read it, but I could read the abstract, shows a satisfactory functional outcome. But let's go back to those 3 cases that I presented. Not one treatment fits all infections. And we have recently worked with the AO group on a classification of these fracture-related infections. And I think with this we have also made a good step forward, because we have defined the most relevant criteria, which is the fracture, the relevant patient factors, and the impairment of the soft tissue. And we have categorized them from 1 to 5 for each parameter, with 1 being the easiest situation and 5 being the most complex situation. And if you do that case by case, you can really analyze your case, you can classify your case, and then you can derive your treatment decision from this. This is the overview on the fracture. You see F1 is the healed fracture, F2 still has a good healing potential, you can retain the implant. The F3, you see that the fracture fixation has failed, you need to do something with bone graft. The F4 situation is a major bone defect, you have to do a bone reconstruction procedure. In F5, you have a destructed joint or an infected bone that cannot be healed anymore, most complex situation. And this can also be adopted to tibial plateau fractures. For example, this case, you see that after the removal of the plates and your debridement, you have a major bone defect. So you end up with an F4 situation. The fracture is not healed, that's clear, a major bone defect that needs then to be reconstructed. And this is our protocol. We do a 2-stage musculae with a hybrid external fixator in order to keep the implant surface small in such a complex situation. That's the hybrid fixator, so you can reconstruct the joint line with a good stability of the leg. Then the revision, you place this antibiotic-loaded PMMA spacer that is left for like 3 to 6 weeks, depending on the soft tissue conditions. Then you create that so-called musculae membrane, and then this is the second stage. You take off the PMMA spacer and you replace this with auto and allograft together with an additional antibiotic-loaded carrier. And this is then the situation after 6 months. After 9 months, then the fixator can be taken off, and this is the situation. Stable healing. The X-ray doesn't look so nice, but it's a stable condition with a good joint reconstruction, and the patient could avoid, and we could avoid any further destruction to the joint. It's at 18 months. So what about this case? So this is a case, you can still see the staples in. The bone defect is there, or there's no bone defect. You see that it's an early stage. You still have the staples, and the bone situation is still good. So this is F2. The fracture is not healed, but it has a good bone healing potential. You don't have to take out the plates. You can leave them in. You can do a so-called DARE procedure with a debridement, antibiotics, and implant retention. So we debride the plate, and we debride the wound, and we put in our local antibiotic carriers with calcium sulfate beads that can be loaded with different antibiotics. And these are then put into the wound, and then the situation can be controlled. Last example, like this, you have a F5 situation. You see the destructed joint, and there is still an infection going on after the joint puncture. In this situation, the joint cannot be saved. We have to do a 2-stage debridement or 2-stage procedure with the resection of the joint, implantation of a temporary spacer, and then the implantation of a hinged total arthroplasty. So please let me summarize. Open fractures and fracture with compartment syndrome are at high risk for fracture-related infections. The infection rates are between 14% for open and 4% for closed fractures. Staph aureus is the most relevant isolated microorganism. Multidisciplinary treatment is helpful, and the fractures should be classified in order to derive the best treatment decision. You can, in most cases, do a DARE or a 2-stage treatment with satisfactory outcome results, and you need a total knee arthroplasty in case of joint destruction. And thank you very much for listening and for the invitation.
Thank you very much. Unfortunately, we are running out of time, so we have to close the session. thank you very much for all of you, especially thank you to my Chinese colleagues. I always learn something from my Chinese colleagues. I always get some innovations. Also Volker, as often as I hear you, but it's always something new for me. So thank you very much. I think it was, for me, a very helpful and learningful session. I also want to thank our industry partners. Without them, it would not be possible to have that exchange, especially Siemens Link and Team Health and Team Imaging. Thank you very much that you are here and also that you support us. So have a good day and a nice congress. Thank you very much. Thank you.